So good afternoon all. Welcome to the second part of the lecture, substance use disorder. We have covered two competencies in the last lecture. One is related to clinical features and another for magnitude of the substance use. Today we will cover two competencies. One is related to laboratory test and another is regarding treatment of alcohol and substance use. So starting with first competency, the lab test related to alcohol use are there are two types of tests for alcohol use. One is direct and one is indirect. Direct is related to the alcohol itself and its chemical reaction with various uh, biochemical molecules. And indirect is when alcohol affects some other organ and other organ reacts and produce some kind of biomarkers or chemicals like mean corpuscular volume, gamma glutamate transferase, aminotransferase, carbohydrate deficient transfer. The first one is blood alcohol concentration. Blood alcohol concentration can usually be measured for less than 10 to 12 hours after alcohol ingestion. And in heavy drinking, it's the main limitation that it can be calculated up to 10 to 12 hours. It is present in breath, saliva, whole blood, and urine also. So determination of breath alcohol with the breath alcohol analyzers are non-invasive test and can be readily available without any invasion. So it is also used for drug driving control by the police department. So blood alcohol concentration is calculated in percentages and the legal limit is 0.03 or less amount of concentration content in the blood, which is 30 milligram of alcohol in 100 ml of blood. For example, blood alcohol concentration of 0.1 means that 0.1 gram of alcohol for every 100 ml of blood. The level above 0.08 are considered impaired and above zero point 0.4 may prove potentially fatal. Another one is ethyl glucuronide. It is very small amount of alcohol which is removed as a ethyl glucuronide by conjugation pathway. And this test is expensive and not yet widely available. The blood ethyl glucuronide concentration peak around 3 hours and can be found in the blood 8 hours after the last consumption. But urinary ethyl glucuronide can be measured up to and can be detected up to 40 to 130 hours and median time is 78 hours, which gives the more window to check the alcohol intake. Similar to EPG, ethyl sulfate is also a minor metabolite of ethanol, and detection window is longer than that of the EPG. And its ETS appears to follow the same pattern of urinary excretion of EPG after exposure. And for this, a specialized chromatographic method are available, and which is a little bit limiting to the in the clinical setup, and it has a little practical advantage compared to EPG. Phosphatidylethylamine, in short, it is PET, is generated through the action of phospholipase D in the presence of ethanol, and it is the specific marker demonstrating alcohol presence of alcohol. Its concentration requires about 15 days of action to return to normal, so one can check for this on an average up to 7 days and ranging from 3.5 to 9 days. Now coming to the indirect lab test, the first one is mean corpuscular volume. Mean corpuscular volume is a mechanism of macrocytosis which is quickly recognized being independent of anemia. And folate and vitamin B12 deficiency means this is independent of the deficiency of vitamins and the condition of anemia. If the person is consuming alcohol for prolonged time and continuously, this MCV will rise. Its metabolic acid, the metabolite acetaldehyde have a toxic effect on the bone marrow. So by the mechanism of immunoglobulin A and immunoglobulin B, which binds to red cell and which can be explanation of the mean increase of mean corpuscular volume or macrocytosis. The MCV higher than 98 is considered evidence of heavy chronic alcoholism, and chronic liquor with the intake lower than the 40 milligrams per day. The upper limit is 98 femtoliters, which is compared with 96 femtoliters for abstinence. And normalization of this takes several months, typically 10 to 12 weeks for the life of the RBCs are usually 10 to 12 weeks, and sensitivity and specificity of this test is 40 to 90%. The next one is GGT, gamma glutamate transferase. This GGT is expressed in many tissues like kidney, bile duct, pancreas, gallbladder, spleen, heart, brain, and seminal vesicles. So it is a kind of non-specific test but can be useful. The gamma GT is a cell membrane anchored enzyme displayed on the outer surface of the cells. The gamma GT also rise on the treatment with drugs like imipramine derivatives, phenytoin, barbiturates, amiodarone, and steroids. So one should keep in mind that patient may not be on these drugs while assessing gamma GT for the alcohol patients. Or several studies also demonstrate that oxidative stress, inflammation, and neoplastic transformation also rises the gamma GT. So in context to alcohol consumption, it's the older and the best biological indicator of heavy alcohol drinking when calculated together with MCV. It is elevated in case of heavy chronic drinking drinkers in 35 to 90% of patients, and a minimum amount of 74 gram of alcohol for men and 60 gram per week for women is required to gamma GT to be raised, and it returns to normal range in about 2 to 6 weeks of abstinence. The limitations are it performs poorly in younger person below 30 years of age. It also rises independent of alcohol in obese person. If obese person is consuming alcohol in little amount, the gamma GT may rise disproportionately to the amount of alcohol consumed. So it has a poor sensitivity because of the multifactorial reasons. So the MCV is considered more reliable than the gamma glutamate transferase, but it is also important as well. Aminotransferases, ASAT and ALAT, also known as SGOT, SGPT. These transaminases enzymes involved in the transamination reaction of amino acids. ALAT is mainly expressed in liver, kidney, heart, and skeletal muscles. And these considered unspecific marker for cytolysis because these are the intracellular enzymes. So how to interpret is ALAT activity is greater than activity is represents liver cytolysis, whereas the reverse is points to muscle cytolysis, including myocardial infarction. Carbohydrate deficient transferrin is CDT formation requires sustained long-term elevation of blood alcohol concentration, and for this reason, CDT is poorly affected by single acute episode of alcohol. So it is a better test to check the chronicity of the alcohol consumption, and greater than 60 milligram per day of alcohol for at least 2 weeks is required to increase this to present this carbohydrate deficient transfer. So how to identify the relapse by means of these tests? The direct alcohol tests are the best to uh, check for the relapses, and ethanol cannot be measured in the blood for more than 10 to 12 hours. So this is the limitation for the direct test, and urinary ETS, which is ETG, extend the window of blood alcohol test for up to 3 to 7 or 9 days. So, relapse will be identified by the direct test in better manner. That returns to normal range after about 2 weeks of abstinence for this reason, together with the high specificity. It is probably to the date best biomarker for relapse, even if low and occasional alcohol consumption may remain undetected. And CDT level normalizes after 2 to 3 weeks of abstinence, but moderate alcohol consumption cannot fully excluded. However, as it is widely available, can be used to detection of relapse. Now the lab test for stimulants, metabolites of cocaine and amphetamine can be detected in blood, hair, sweat, saliva and urine. In clinical practice, the urine and blood testing are most useful and are widely practiced. Blood testing can be helpful to assess for acute intoxication and very recent ingestion after recent ingestion of the substance. Urine testing is often used as a means of monitoring patients for relapse and detecting concurrent use of other illicit substance also. For cocaine, metabolites may be detectable up to 2 weeks after cessation of some heavy users. Methamphetamine is generally detectable for longer periods of time than the cocaine. Uh, Synthetic cathinones present more of a challenge because as many are not detectable by routine drug screening and gas chromatography is necessary when cathinone ingestion is suspected. For caffeine, blood serum level greater than 100 microgram per ml will be lethal, and patients up to level of 200 microgram per ml are reported to be surviving after the intoxication. And the serum caffeine level may be poor indicator of toxicity due to variable relationship between blood concentration and toxic effect. So the level of this caffeine presentation is variable. Urine or blood drug screen can also be used to rule out the presence of the drug in the body along with the caffeine. For cannabinoids, it can be detected in head hair, pubic hair, urine, sweat, saliva, and blood of users. It is stored in the fat cells in the abundance, and level of THC means tetrahydrocannabinol in blood above 10 to 15 nanogram per ml indicates recent use. And the more precise is when the THC to 9-carboxy THC level is 1 is to 1 or are similar. That indicates this the cannabis has been used in the past 20 to 40 years. For hallucinogens, urine toxicology may be useful to establish the acute ingestion. And other than PCP and MDMA, will not be detected with the routine urine drug screen. False negative screen for PCP are not uncommon. Information from friends and history is important, making the clinical diagnosis and suspecting the hallucinogen intake. So MBA usually detected in the case of overdose, and it presents as a serotonin syndrome, which occurs due to the drugs which inhibits the increase the serotonergic transmission. For volatile substance, it is very difficult to assess in the lab because the reason one is the compound have a relatively brief life, it's a very short life. The compound occurs in urine and these may volatilize in the urine while taking the sample, storage or transportation. The hippuric acid, a toluene metabolite, can be detected longer than toluene, but hippuric acid also be produced from food and raising a question of false positive test. The fourth one is inhalants may bind to the plastic of urine cups or breath collection bags and reducing the concentration into false negative test. So for collection of volatile substance, tightly sealed glass container with little or no air space, and these can be carefully refrigerated until analysis. And it is analyzed by gas chromatography followed by flame ionization, electron capture, and mass spectroscopic procedures. The simultaneous analysis of ratio of sulfuric acid to creatinine may reveal recent or tooling use, and even under ideal condition, it has a shorter life and has much less valuable clinically. For opioid, again, urine toxicology is important and it is detected in urine. The drugs are first detectable in urine from 2 to 6 hours after use, and the morphine, heroin, codeine, and hydrocodone can be detected from 1 to 3 days, and its metabolite 6 AM can be detected in urine up to 8 hours after last use. The polysynthetic opioids such as methadone, fentanyl, buprenorphine, tramadol, oxycodone require specific urine toxicology tests. Hair clippings can uh, detect the opioid consumption over the preceding 2 to 3 months, so it can be helpful in chronic abusers. Hair testing is better indicator of chronic use. For nicotine, there is cotinine, which is the mm, metabolite of nicotine, and it is also used nowadays for treatment of depression. Not used, being studied for use in depression, PTSD, schizophrenia, Alzheimer's, and Parkinson's. The drug test can detect protein in blood, urea, and saliva. So the level of blood, urine, saliva protein can be interpreted as the in the no active smokers it is less than 10 nanogram per ml. For light smoker or moderate casual smoker, the blood level will be 10 to 100, urine level will be 11 to 30, and saliva level will be 1 to 30 nanogram per ml. For heavy smokers means the person who is smoking more than 20 cigarettes per day, the blood level may be found more than 300 nanogram per ml, more than 500 for urine level, and more than 100 in the saliva. So the noteworthy point is, if the person is on nicotine replacement therapy, the test may come positive in the abstainers. So this was regarding the lab test for various classes of drug. Now we will discuss about the treatment part of the substance use disorder. Starting with intoxications, the alcohol intoxication. If the person is conscious and can swallow, give them water and have them lie on their left side to prevent expiration. If the person is unconscious, turn them on their left sides and administer fluids intravenously to prevent dehydration. Because alcohol is also acts as aldosterone-like substance is causing dehydration. Intubation to open airways and provide more oxygen to the body. Abdominal stomach lavage can also be done to get rid of excessive alcohol. So basically, the protocol for poisoning is followed in case of acute intoxication. Otherwise, if any antidote is available, then that can be given. In opioid intoxication, maintenance of airway and rescue the breathing because it is it cause respiratory arrest. Initial intravenous dose of zero point 0.4 to zero point 0.8 milligram of naloxone can be used to reverse the toxicity, and the case report as high as 100 milligram of naloxone required for successful resuscitation is there. Basic life support and advanced cardiac life support principles should be followed, and after recovery, referred for de-addiction to the psychiatrist. Cannabis intoxication, usually mild and self-limiting. Anxiety, panic, psychosis are best treated symptomatically with benzodiazepine for anxiety, antipsychotic for psychosis, and no medication is approved specifically, so there is no antidote. So supportive treatment is the mainstay. And studies suggest that selective CV1 receptor antagonist and inverse agonist rimonabant can have some useful effect to reverse the cannabis intoxication. Stimulant intoxication, there is no reliable, effective, specific drug is available. Supportive care is mainstay. While self-lifting, stimulant intoxication can be complicated by toxic reactions including paranoia, agitation, seizure, hypertension. So, supportive treatment and supportive drugs as and when required is ministry of the management. Similarly, for caffeine intoxication, caffeine has a relatively short of life and short-term management of the patient can be supported. Uh, for the patient who repeatedly experience episodes of caffeine intoxication, the clinician must assist the patient to recognize his or total daily caffeine consumption and through the use of daily diaries and teach the patient to the adverse effect and cut down the intake of the substance. Hallucinogen intoxication. Uh, for this, provide a quiet environment for the patient, preferably free from the external stimuli because external stimuli can exaggerate the hallucinatory perception. Provide one-to-one supervision to ensure the patient does not cause any harm to themselves or others. A low dose of benzodiazepine may sometimes be indicated to control anxiety and the individuals who have taken the large doses of LSD are at risk for residual psychotic symptoms and therefore managed with antipsychotic drugs if symptoms manifest and persist. The LSD treatment is mainly supportive. Autonomic symptoms may require symptomatic treatment like clonidine or fluoxetine. Volatile substance, inhalant intoxication usually self-contained and resolves on its own. The majority of treatment and management focus on addressing the underlying disorder. Now coming to the dependence, how the dependent patient is treated or the process of de-addiction is happens. So the protocol is the person you first usually detoxify and the body cleansing of the substance is done, which is known as detox or detoxification, and the further counseling and behavior therapy to combat with the various psychosocial aspects and to relapse prevention. Rehabilitation program can be employed and self-help group also are helpful in support groups like Alcoholic Anonymous, which provides peer support and encouragement. So the etiology is multifactorial, then treatment will also be multifactorial. First, the patient will be treated with drugs to detoxify. So starting with detoxification of alcohol, the main recommendation of guidelines like NICE, ASAM, WF, SDP, and APA guidelines. The first line of treatment are benzodiazepines. The second line is carbamazepine. Thiamine is provided to prevent vernicitis for some of encephalopathy or to prevent or treat this encephalopathy. Alpha 2 adrenergic agonists and beta blockers can be used to take care of the severe adrenergic hyperactivity, like clonidine as a alpha 2 adrenergic agonist and propranolol as beta blocker. The regime for benzodiazepine to detoxify is uh, here for diazepam, lorazepam, and chlordiazepoxide. These three drugs are usually used in the clinical practice. Other benzodiazepine can also be used, but the dose of that should be calculated against the standard dose of the diazepam. So when using diazepam for mild withdrawal, 5 to 10 milligram of drug is needed orally. For moderate withdrawal, the day one is 15 to 20 milligram QID. QID means in 4 divided doses. Then reduce it to 10 to 20 in QID dose for day 2. And day 3, 5 to 15 milligram PDS. Day 4 is 10 milligram QID. Day 5 is 5 milligram QID. Then the drug can be stopped. In severe withdrawal, 10 to 25 milligram orally as needed every hour while awake until sedation occurs. And for lorazepam, low dose of 1 to 2 milligram is required every 4 to 6 hours for mild withdrawal for 1 to 3 days. And for moderate withdrawal, it is 2 to 4 milligram QID for day 1 and 2, and 1 to 2 milligram QID for 3 and 4 days. The day fifth is 1 milligram BD, and then it can be stopped. And for severe withdrawal, intravenous lorazepam can be given hourly, and while the patient is awake for 3 to 5 days. So sedation is required to uh, combat the withdrawal symptoms of alcohol. Chlordiazepic oxide is a long-acting benzodiazepine. In low dose, it is required in mild withdrawal. For moderate withdrawal, it is 20 mg TDS on day 1, then tapering it to 50 milligram TDS, 10 milligram TDS, 5 milligram TDS, 5 milligram VD day 5, and then can be stopped. Higher dose is required for severe withdrawal. This is the drug dose conversion chart for various benzodiazepine against the 60 milligram dose of diazepam. The equivalent dose for various drugs are as follows. For alprazolam, it is 6 milligrams. For chlordiazepic oxide, it is 150. For clonazepam, 24. Flurazepam, 90. Elazepam, 240. Lorazepam, 12. And oxazepam, 16. When the person put on benzodiazepine, the tapering of the benzodiazepine is required gradually to uh, not to have the withdrawal symptoms of benzodiazepine itself. So, starting with the higher dose, by and large, the idea is after 3 days, the 33% of dose can be reduced. If diazepam is started with 30 milligram, it can be reduced to 20 milligram after 3 days, and after 6 days, again 25% dose reduction can be done, and 15 milligram of the diazepam is reduced from 20, and then 10 milligram after 9th day, and after 12th day it is reduction of 50% of those previous dose of 10 milligram, that is 5 milligram. So gradual reduction is done to reduce the withdrawal effect of the benzodiazepine, and this is implied for benzodiazepine itself also. If the person is abusing benzodiazepine, this protocol is applied for gradual tapering the drug. Now the complicated withdrawal symptom Wernicke's-Korsakoff. Other than benzodiazepine in higher doses, either orally or IV, to prevent Wernicke's-Korsakoff syndrome in complicated withdrawal, the prophylactic thiamine is required, which is 200 to 300 milligram per day for 5 days, IV or oral, which is total of 1000 and 1500. When it is calculated on the basis of amount the person is consuming, the preventive thiamine can be given in such a manner. For corrective treatment, even when it is not suspected, the use of high dose like 500 milligram infused over 30 minutes, 1 or 2 times per day for 3 days. And if it is suspected that the person has developed WE, Wernicke's encephalopathy, 500 milligram thiamine to be infused at least 3 times a day for 5 days along with the multivitamin injections. The point to be noted here is intravenous dextrose should never be used in alcohol withdrawal as it might precipitate Wernicke's encephalopathy and the thiamine-related cardiomyopathy in vulnerable individuals, as we had discussed in the previous lecture that thiamine is the coenzyme which is required for metabolism of glucose in Krebs cycle. So, do not replenish the glucose before replenishing the thiamine. So isotonic saline is to be used for thiamine injection or other vitamin injection as infusion, and dextrose could be safely administered once the patient is received thiamine. For opioid detoxification, various classes of drugs available are opioid agonist itself for replacement therapy, partial agonist also for replacement therapy, opioid antagonist like naltrexone or naloxone as a blocking agent in relapse prevention. Non-opioid drugs like alpha-2 adrenergic agonist, the drug is clonidine for autonomic hyperactivity. For substitution therapy, the drugs which is mainly used is methadone, buprenorphine, tramadol, and tapentadol. Methadone and buprenorphine is approved drugs. The dose regime for buprenorphine is when the withdrawal starts to happen, then only start the drug. On day 1, 2 to 4 milligram of buprenorphine every hour for 4 hours. Total dose of 8 to 12 milligram should be given on the day 1. On day 2, 16 milligram in divided doses, that is 8 milligram twice daily is done on day 2, and day 3 to 9 decrease by 2 to 4 milligram per day as tolerated. Add clonidine if autonomic hyperactivity symptoms are there. For methadone, day 1 begin with the 10 milligram and increase by 10 milligram every 6 to 8 hours for maximum dose up to 40 milligrams. Then for day 2 onwards, there are two options. Option 1, for day 2 to 4, decrease the dose by 10 milligram each day and decrease the dose by 2 milligram each day further for 5 to 8 days. In option 2, from day 2 to 8, decrease the dose 5 milligram each day from the initial dose. The clonidine, when used for autonomic hyperactivity, the day 1, 0.1 to 0.2 milligram every 4 to 6 hours with a maximum dose of 1.2 milligram, and taper by 1, 0.1 to 0.2 milligram per day. And keep in mind this is central sympatholytic, so BP can drop. So keep check on the blood pressure of the patient as and when required. And for lofexidine, it is day 1, 0.5 to 0.7 milligram every 6 hours. Day 2 onward, decrease each dose by 0.2 milligram every 1 to 2 days. Ancillary medications which are used in detoxification of opioids are clonazepam for anxiety. For muscle cramps, ibuprofen can be used. For nausea, vomiting, diarrhea, ondansetron, chlorpromazine, pyrazine can be used. For sleep, trazodone and zolpidem. For cannabis, either CB1 receptor agonist may be used, or the drugs which indirectly alleviate the symptoms of cannabis withdrawal. So we will look at what is the available drugs. The antidepressants, bupropion and divalproex worsens the withdrawal of cannabis, so should be avoided. Cloxetine reduce the cannabis use and can be used in relapse prevention. Nefazodone improves anxiety in cannabis withdrawal. Lofexidine with the tetrahydrocannabinol reduces the withdrawal. The cannabis agents like oral THC 30 to 90 milligram reduces the withdrawal symptoms, and dronabinol has mixed results. Rimonabant can attenuate the effect of cannabis in case of toxicity. Sedative hypnotic anxiolytics are benzodiazepine and barbiturates and should follow the rule for as for the uncomplicated withdrawal for benzodiazepine. The dose should be gradually tapered down over the period of days. For stimulants, there is no reliable, effective, specific pharmacologic treatment is available. Supportive care is the mainstay, and unlike the withdrawal syndrome described for alcohol, benzodiazepine, and others, these are milder, self-limiting, and not typically associated with delirium or other medical complications. Similarly, for cocaine, there is no approved medication to treat cocaine use disorder is available. Trial of direct dopamine agonist, which increases presynaptic dopamine release, has not shown any benefit in the cocaine-dependent patients. Dextroamphetamine has a mixed report of therapeutic response. The atypical psychostimulants, modafinil has shown little benefit in detox of cocaine. A sustained release formulation of methylphenidate did show benefit in one study. Opioid antagonist naltrexone and typical and atypical antipsychotics and the D1 receptor antagonist ecopipam have all been investigated, and none have shown clear evidence of benefit in placebo controlled trial. Disulfiram also appears to have more direct pharmacological effect on metabolism of dopamine and cocaine itself, and found somewhat helpful in the cocaine detox. Drugs like baclofen, tiagabine, modafinil, which likely affect the GABA and glutamate neurotransmission, have failed to show any benefit. So the withdrawal of this, by and large, is supported. Detoxification of caffeine. So symptom of caffeine withdrawal typically resolve with the ingestion of last dose of caffeine, and a person who is having the symptoms of withdrawal of caffeine more than 2 weeks should be carefully re-evaluated, because it does not last for more than 2 weeks. Caffeine withdrawal headache may respond with aspirin and other analgesics. The withdrawal, if the withdrawal occurs because a person is attempting to abruptly stop all the caffeine, advise the patient to taper the caffeine consumption over the period of time. So this should also be gradually reduced to detoxify. Hallucinogen withdrawals. So in the hallucinogens, there is no recognized syndrome of withdrawal is found in humans for any class of hallucinogen. And although there is evidence of clinically meaningful withdrawal in case of heavy MDMA use, and the evidence of PCP withdrawal in animal models. So supportive treatment is the mainstay. No specific drug is uh, described for hallucinogen withdrawal. The efficacy of psychosocial treatment that have an empirical support for treatment of other substance use disorder is unknown in case of hallucinogen use disorders. For volatile substance, case studies of pharmacological intervention have evaluated the drug like aripiprazole and lamotrigine to reduce craving, baclofen for withdrawal symptoms, for neuropsychiatric symptoms like anxiety, panic, and psychosis, carbamazepine, haloperidol, and risperidone have tried, and behavioral symptoms such as increased locomotor activity, in that case, vigabatrin is tried, and although many of these case studies report positive finding, but the literature is very scanty and lacking the vigorous evidence. So treatment is supportive for these volatile substance. For nicotine withdrawal, the protocol is to set a quit date. It is not an immediate thing. Set a quit date for the nicotine stoppage, and most clinicians prefer this sudden stoppage of the abuse of nicotine, but the gradual stoppage is also a good idea. Too. The person should be taught about the group therapy, weight gain concerns, high risk situation, and making cigarettes unavailable. This should be discussed with the patient in psychotherapeutic sessions. So, because the relapse is often rapid, the first follow-up and visit should be after 2 to 3 days of the last quit date, because it's very difficult to quit, and the factor of social sanctioning is also there with the nicotine, so it is very difficult to cut down this nicotine. The pharmacologic agent which can be used in reducing the craving of nicotine, you all know that nicotine gums are available, nicotine patches are there, micro tablets, lozenges, inhalers, and nasal sprays of nicotine are available for nicotine replacement therapy. In non-nicotine medications for nicotine withdrawal, bupropion can be used in 50 milligram per day to 300 milligram per day doses to reduce the craving, and clonidine can decrease the sympathetic activities. Nicotine vaccine is under investigation, so if the nicotine vaccine is available, then it will be useful for the person who is using nicotine. There is a one drug, varenicline, which is cholinomimetic alkaloid, is said to have decreased the craving of nicotine. Doses are from day 1 to day 3, zero point 0.5 milligram oral dose once a day is needed, and from 4 to 7, zero point 0.5 milligram orally 2 times a day is needed, and at the uh, day 8 to the end of treatment, 1 milligram orally 2 times a day is required, and the usual duration of therapy is around 12 weeks. So other than drugs used for detoxification, there are other drugs are also available for relapse prevention, like anti-craving drugs, blocking agents, and aversive drugs are available. In anti-craving drugs, acamprosate, baclofen, naltrexone can be used for alcohol. Topiramate also useful in alcohol relapse prevention. Naltrexone is anti-craving and it is also blocking agent. This is blocking agent for opioid abusers because it is mu receptor antagonist. Gabapentin, varenicline, ceticoline uh, can be used for anti-craving agent. The blocking agents are naltrexone, naloxone in case of opioids, and rimonabant in case of cannabis use. Aversive drug is disulfiram, which is used for alcohol abusers. Disulfiram usually blocks the metabolism of alcohol, and a little more amount of alcohol rushes in the blood, and it causes more adverse effects. So, in case of disulfiram, the patient is first counseled, and if the patient is highly motivated, then only this drug can be given, because that in case of alcohol consumption in presence of disulfiram, it may lead to adverse reactions like seizure, coma, and death also. So the person have the aversive reaction because of the alcohol due to presence of disulfiram. So the person knows that I don't have to take the substance while I have on this drug. So this kind of aversion is done in alcoholic patients with disulfiram. After detoxification, the psychological therapies are also important uh, as equal to the drugs because of the relapse prevention. Various psychotherapies and the behavioral therapies are available and can be applied or applied to the patient as per their requirement. So, cognitive behavioral therapy is there to recognize, avoid, and cope with the situation in which the person most likely to use the drug. So the person's cognition and behavior is taught to the patient, and person try to change his cognition and behavior after uh, during the psychotherapy. Contingency management uses positive reinforcements such as providing rewards and privileges for remaining drug free, for attending, participating in counseling session, and taking treatment medication as prescribed. This is the contingency management. Motivational enhancement therapy can be done who was in the patient who are in the denial mode, and they can be prepared for readiness to change their behavior and to enter in the treatment. Family therapy is also important because the etiology is multifactorial. Psychosocial factors like interpersonal relationship between the family members, between the couples and others may be contributory factor to the relapse or to sustain the substance abusing pattern. So family therapy can be done in such a cases. And the 12-step facilitation known as Alcoholic Anonymous is a self-help group which is run by the abstainers itself and maybe under the guidance of some expert clinical psychologists or psychiatrists. The person who are involved in this self-help groups who has quit the substance for a long time and their behavior is pervasively sober for years or for such a long time. So thank you for the patient listening. So we had covered what about the lab tests and the treatment of various drugs intoxicated state and detoxification under the de-addiction program for dependent patients. So thank you, thanks for the patient listening. If anyone have any question and can ask,